Good morning and welcome everybody. I now start my remaining part of pulmonary vascular hypertension. Anesthetic and hemodynamic goals for patients with pulmonary hypertension. Avoid elevations in pulmonary vascular resistance. Prevent hypoxemia, acidosis, hypercarbia, and pain. Provide supplemental oxygen at all times. Maintain the SVR, that is systemic vascular resistance. Decrease SVR dramatically reduces cardiac output due to fixed pulmonary vascular resistance. Avoid myocardial depressants and maintain the myocardial contractility. Maintain the preload. Maintain the sinus rhythm. Pulmonary arterial catheter should not be placed in patients with Eisenmanger's physiology. Transesophageal echocardiography should be considered if available. General anesthesia, sedation, supplemental oxygen should be used and preoperative sedation minimized to avoid hypoxia and hypercarbia. Induction. Anesthetic induction can be challenging due to the high resting sympathetic tone and resultant deficiency of catecholamine levels. This can result in exaggerated hemodynamic compromise following induction. As such, induction should be titrated slowly to effect. Induction are to be carried out using a slow titration of narcotics, followed by an induction agent such as etomidate 0.2 to 0.4 mg per kilogram to limit the hemodynamic changes. Lidocaine, that is 1 mg per kilogram, may also help blunt the response to intubation and should be considered. Maintenance of anesthesia, combinations of inhaler agents along with IV narcotics or benzodiazepines should be titrated to effect. Now, fluid management. Attempt to maintain euvolemia as close to baseline as possible. TEE, that is transesophageal echocardiography, and pulmonary arterial catheter measurements should guide the fluid management with care taken not to overwhelm the RV function, right ventricular function. Maintenance of hemodynamic management. If hypotension is observed, determine if it is due to right ventricular failure or inadequate preload. Assuming euvolemia, inotropic therapy must be considered. Consider dobutamine, beta-1 agonist, or milrinone as IV and inotropic therapy. Both agents are considered inodilators and may result in systemic vasodilatation and hypotension, which can usually be treated with phenylephrine or norepinephrine. Therapeutic options for hemodynamic support in PH, that is pulmonary hypertension. Direct acting pulmonary vasodilators requiring modifying circuit, consult the respiratory therapy for assistance. Inhaled nitric oxide 20 to 40 ppm blended into inspiratory arm of circuit. Inhaled prostacyclin nebulized 50 nanogram per kilogram per minute or 50 microgram over 15 minutes every 1 hour. Pulmonary systemic and systemic vasodilators plus increased cardiac contractility. Dobutamine infusion 2 to 20 microgram per kilogram per minute. Milrinone infusion 0.5 to 0.75 microgram per kilogram per minute. Consider for cases of pulmonary hypertension refractory to nitric oxide therapy. Dipyridamole bolus can be given 0.2 to 0.6 milligram per kilogram over 15 minutes per 12 hours. Systemic vasoconstrictors like phenylephrine infusion 10 to 200 microgram per minute or norepinephrine infusion 0.2 to 3.3 microgram per kilogram per minute. Inhaled nitric oxide, a potent pulmonary vasodilator, starting dose 20 to 40 ppm, which has minimal effect on the systemic circulation. Nitric oxide requires special equipment to administer inline in the anesthesia circuit, and not all hospitals have nitric oxide available. Nitric oxide must be weaned slowly, so once started, the patients will need to remain intubated as nitric oxide is weaned in the ICU. Inhaled prostacyclin has also been used intraoperatively either as continuous inhalation therapy, that is 50 nanogram per kilogram per minute, or as an hourly inhaled bolus, that is 50 microgram over 15 minutes. Vasoconstrictors such as phenylephrine, norepinephrine and vasopressin may have variable response on pulmonary vascular resistance, but may be needed in the setting of persistent systemic hypotension. Ventilator management. Avoidance of hypoxia and hypercarbia is critical, but must be balanced by avoidance of lung hyperinflation. Large alterations in the lung volumes by positive pressure ventilation, along with either excessive or inadequate PEEP, can dramatically alter PVR, that is pulmonary vascular resistance, in pulmonary hypertension patients. Low tidal volume ventilation with low PEEP levels may be the ideal strategy, adjusting respiratory rate to prevent hypercarbia. Hypercarbia dramatically elevates the pulmonary vascular resistance and is a risk with this ventilation strategy and must be monitored carefully. Post-operative management. The post-operative period is a high-risk time for pulmonary hypertension patients. The pulmonary hypertension patients should be monitored in an intensive care setting in the first few days following surgery, as there is high risk for sudden death. Patients may benefit from epidural anesthesia for post-operative analgesia. Finally, the patient should be transitioned back to the usual oral anticoagulation post-operatively. Now, summary for pulmonary hypertension. Definition. Mean pulmonary artery pressure more than 25 mm mercury can be either primary or secondary pulmonary hypertension. Assessment. Thorough history can be invaluable. Evaluation by specialist in PH, pulmonary hypertension, before elective surgery is recommended. Transesophageal echocardiography or right heart catheterization is key to evaluate the etiology, current right ventricular function and response to vasodilators. Consider preoperative ABGs. Risk. Patients are high-risk surgical candidates. Elevations of pulmonary artery pressure can result in right ventricular failure, leading to hemodynamic collapse. Monitoring. Arterial line for most procedures. Consider central line, pulmonary artery catheter or transesophageal echocardiography as indicated by surgical risk. Anesthetic management. Regional anesthesia probably is first choice. Tailor the anesthetic to minimize the alterations in the preload or afterload. Avoid hypercarbia, acidosis and hypoxia. Consider inhaled nitric oxide for severe pulmonary hypertension patients. Maintain all outpatient pulmonary hypertension medications throughout the perioperative period. Thank you, and this is the end of my lecture series on pulmonary hypertension.